you're in a scenario where you are the specialist, you have been trained as a specialist, and then, but you are not making an impact, and then you want to begin to make an impact. Then something happens. Something happens. You got to get other people on board. Where there is insufficient dissatisfaction with the present situation, it is often helpful to create some form of dissatisfaction before pushing for a change. The question we must answer is, what is likely to happen if we do nothing about our situation? What will likely happen? That is a very valid question. The B of the second function is B, which is a shared vision. Even though people may not like their present situation, they will not move as a group until they agree on where they want to go. Individual visions are not enough. They must be shared. You cannot be a specialist and imagine that you as a specialist will simply impart upon your system when your own colleagues have not accepted it and they have not paid into the vision that they are trying to drive. Satisfaction without a common vision will lead to despondency, and that means living without hope. The D function is knowledge about the first practical steps. You have A well done, you have B well done. The next is knowledge about the first practical steps. What are you going to do? The energy of many groups is immobilized by frustration. Why? They don't know how to start. They don't know how to start. And dissatisfaction and shared vision is not all that you need.
Part 2C.
Yeah, there's so much disturbance at the background. People mute your mics, please. Dissatisfaction and shared vision is not enough if you can't think of some initial ways forward. Thank you for meeting everybody. In order to give people the confidence to move, it is often necessary to break the change down into small, manageable steps. So what to do? What to do? What to do? The cost of change. You have A well, B well, D well, all of these are good. Then the cost of change are numerous. What are these costs? Time. It will engage your time. It will involve personal energy. It will involve some effort. If you are going to have to change, they're going to awaken the specialist in you. It may even require some money because you want to make some additions in the system where you're operating. There could be the risk of demotivation because we are trying to push for a change and the system is just resisting so strongly. There might be a feeling of uncertainty. How are they going to take it? Even an element of turbulence in the system because change is like a strange protein that the body rejects any given point in time. And rejection could just be a factor, while change may be difficult. The psychological cost is that of the owner. There are persons in the system that will say, this is the way we have been doing it all along. So once those people are there and they do not key in, and you cannot get them to key in, then the process becomes very difficult. But if you are going to carry out the change, then there's the process you must follow. Stage number one. What is your present situation? Diagnose your present situation. Describe your present. If you don't know where you are, you cannot be talking about whether where you are going to go is going to be better than where you are. So you got to know where you are and then define the future. If you are unable to define the future, you will not be able to know when you arrive in that future. Define the future. Then take the future and take where you are, even diagnose where you are, and then see the gap that exists between where you want to go, where you want to get to, and where you are now. And then analyze this gap. Thereafter, put a structure in place how you can move from where you are to where you want to be. Then manage that transition. As you manage the transition, once you have gotten there, and you have been able to take your first step and you arrive safely, consolidate the change. You need to consolidate it because if you don't consolidate it, then it will not be sustainable. And for the awakened specialist is a change agent, positive change agent. You find personal fulfillment when you are awakened. In fact, you have professional respect. But that process itself is going to earn you promotion as a consultant. In fact, you become a pace setter, and then you become a positive reference point. I will illustrate this. The case study of unit dose dispensing system in Nigeria. as a way of illustrating this issue of having to awaken the specialist in you. It was a discussion that I had with pharmacist Obiaga. The picture, we can see pharmacist Obiaga sitting with me. This was in 2001 at the pharmacy curriculum conference of the Pharmacists Council of Nigeria, then Pharmacists Council of Nigeria, Sangota, Nigeria. I made a presentation of pharmacy administration in a professional faculty curriculum in Nigeria, while pharmacist Obiaga presented on hospital pharmacy in the program. After the program, he expressed frustration on the lack of adoption of UDDS in health facilities in Nigeria. I assured him we're going to do something. That was recognizing the specialist. He has been doing that in ABU. I didn't even know what UDDS was all about until we met. And from that point in time, I made up my mind I was going to get this to happen. And therefore, the place to start is to read it up. The place to start is to make myself a specialist without a certification. Got back to Ife and decided to organize the first national workshop. You can see Professor Gundaini is there at the center. It was Dean at the time. Yes, I think so. And then the first national, that was in 2002. About 20 institutions actually were represented. After the workshop, participants from different institutions were fired up, just like I hope somebody's been fired up at this time. We're fired up to adopt the UDDS. And the UDDS remains the easiest way for pharmacists to gain unhindered access into the hospital world. That is the easiest way. And the Akwa Ibom State government invited us, Obiaga and myself, sometime to also start the full statewide implementation of UDDS. And then in 2010, I was contracted as a consultant at the UCH in order to assist them establish the UDDS. The advantage that had was that the number of pharmacists, established position for pharmacists was increased, and also the number of pharmacists that access the world also shot up. In the national scale, UDDS was like a sleeping specialist in pharmacy Obiaga, who can rightly be regarded as the father of UDDS in Nigeria. We succeeded through a systematic process that resulted in UDDS now being implemented in some hospitals in Nigeria. That was awakening the specialists. No child can be born without father, which is a sperm, and then mother that produces the ovum. The birth of a baby called UDDS in Nigeria, I regard as a product of the union of the father of UDDS, pharmacist Obiaga, and with all respect, the mother of UDDS, my humble self. In ending, the ladder of success works like any other ladder. Very few have climbed it with their hands in their pockets. You are the way you are because that's the way you want to be. If you really wanted to be different, you will be in the process of changing right now. If you are certified as a specialist and you don't recognize that you're a specialist, the people around you will not see the specialist in you. Until you awaken the specialist in you, nobody will recognize that you're a specialist, even if you are certified. That is why you find a patent medicine dealer is called a doctor. And then you find that the pharmacist is not seen as a doctor in the settings where they operate. Why? One has not been awakened the specialist in him. Don't wait until you feel like taking a positive action. Take the action, and then you will feel like doing it. This is the way to start. You become great by doing small things in a great way. Nothing will ever be attempted if all possible objections must be overcome. It does not matter the setting where you are. If you awaken the specialist in you, you can make a difference. You can make a difference. One definition, somebody said, of insanity is to believe that you can keep doing what you have been doing and get different results. Thank you so much for your kind attention. God bless you.
Thank you very much, sir.
Thank you.
Thank you very much, sir. Thank you for this charge.
Thank you, sir.
For this
Thank you,
charge.
Prof.
This is really awakening.
God bless you, really good, sir.
Thank you. Moderator, just give me a minute. Let me do some recognition before we call the next speaker. All right. So at this point in time, I want to recognize more fellows on the call. I want to recognize all zonal coordinators of the West African Postgraduate College of Pharmacists. You are welcome. I want to recognize professors on the call, Professor Bola Joko-Aina, Professor Shure Mekun, Professor Uriagba, the SG, they are all on this call. The national chairman, Ahapin, we recognize you on this call, and other distinguished fellows. Please, you're all welcome. Just sit back, relax, take your notes, pads and pen, and jot down, because like Professor Enru has said, after this webinar, the specialists in us should be awakened, and we should go out to make sure we are known and recognized. Thank you very much. Over to you, moderator.
Thank you, Professor Enru, for this excellent presentation. You agree with me that Professor Enru has actually done justice to this topic. He has quickly reminded us that the main thing about this whole practice of clinical pharmacy is identifying who we are. He has quickly identified the difference between a generalist and a specialist. These are these sleeping specialists. And he has quickly also elaborated on the change of process model, what we need to do, and not just sitting back. We need to awaken that spirit in us for us to move ahead and actually get a space in the clinical arena. Thank you so very much, Professor Enru, for this presentation. So I'll quickly call on Professor Ogundiani for his presentation, but shortly before then, please, we just want to have our the president of the West African Postgraduate College of Pharmacists, and the president of Professor Uriagba, to give us his goodwill message.
Thank you very much, Dr. Ebele, moderator. I'm the SG, not the president.
Sorry.
Thank you very much.
General, sorry.
Yes, thank you very much. I really want to commend the Nigeria chapter, West Africa Postgraduate College of Pharmacists, and for organizing this fantastic program. I recognize the president of the college, distinguished Professor Cecilia Aguilo. I recognize the chairman of the Nigeria chapter, Dr. Margaret Obono, and all the professors on board. I really appreciate our professor, the speaker, Professor Wilson Enru, my teacher, who has given a very, very inspiring talk. God bless you, sir. All other professors, you are all well recognized. The college is aimed, or one of the goals of the college is to produce specialists. And we are proud to say that we are indeed producing specialists. Not just specialists, but specialists that are impacting on the system. There are many of our specialists that we are so proud of. Why are we proud of them? The physicians will not work without them. They need them to function effectively. That is why we are proud of them. And it is because they have been able to reawaken the spirit in them. Just like Professor Enru said, when you awaken the spirit in you, you are charged. Then you become passionate about what you are doing as a specialist. And you want to impact. And when you impact, that brings fulfillment, that brings happiness. You can only be happy when you are happy doing what you are doing on a daily basis. In fact, it's better than being recognized by the government. It's better than being paid when you really understand what you are doing as a specialist and you are making the impact. It becomes fun. So indeed, we are very, very grateful to the first speaker, and I'm sure the subsequent speakers will do justice to the topic. Once again, thank you so much, Nigeria chapter. You are doing very well. And I want you all to stay behind till the very last, because I know that we still have a lot of mind-blowing discussion coming up. Thank you very much. God bless you all. Over.
Okay, thank
Thank
you
you very much, SG.
for your goodwill message. And I'll call on Professor Abiodun Ogundaini, a professor of pharmaceutical chemistry.
Good morning. Am I communicating?
Welcome,
well.
sir. We can hear you.
We can hear you, sir.
Thank
Yes,
you
sir,
very
you're
much.
communicating, sir.
Good morning. I want to thank the organizers for inviting me to come and reflect on consultancy and pharmacy consultants, and I'm very grateful to them. I also want to thank my colleague, Professor Eru, for laying a very good basis for what I'm about to discuss. I was given the topic, who is a consultant pharmacist? My talk will be in two tranches. I'll first of all look into consultancy before I relate it to pharmacy. But in between, I might be using pharmacy examples as we go along. But I want us to reflect even on who is a consultant pharmacist. I gave this talk in MCPD, something like that sometimes. And while I was preparing for it, I saw a write-up from a pharmacist who later became a doctor, who is querying why we're using consultant pharmacists rather than pharmacy consultants. And the reason is this: by virtue of our training, although we might be a generalist, we're specialists of a kind, specialists in drugs. And when we specialize, you specialize in different areas. Even in clinical pharmacy, people can specialize, or in hospital pharmacy, you can specialize in oncology, geriatric, and so on. And so, he queried that pharmacy consultants will be better than consultant pharmacists, because as pharmacists, we are all consultants of some form. Yes, some will be specialists. I want us to reflect on this for discussion. My view is that I tend to agree with you, but that's beside the point. So what is consultancy? It's an expert advice on a particular subject by a person that is paid to provide to another person, a company or organization. That's Collins Dictionary. And the expert who does that is a consultant. When I have two types of consultants, internal consultants, you operate within a system, organization, and you are consulted in your area of specialty. That is, you work at the site of the organization. A pharmacist consultant or consultant pharmacist working in a hospital is in this setting. So is a consultant gynecologist or whatever. They are internal consultants. But we can also have external consultants. That is someone who is employed from outside the organization on a temporary basis to provide an expertise. And he would have multiple clients. He works at his own base, but whatever he does, he still goes to the site of the person who employed him to do the job. Pharmacists too can be external consultants, because as a consultant pharmacy or pharmacy consultant, you can be invited to a hospital, to a pharmacy setup to advise. So I think it's still relevant to look at consultancy in general. Now, what are the benefits of internal consultants? They are part of the organization, they understand the organization, and they are there to implement part of what they are suggesting. I'm so happy, or I was so happy, the example Professor Eru gave. He learned about UDDS. His operating base is in Ife, and he came back and he worked to start it in Ife, and even had a conference. So they have existing relationship with other employees, and that will foster better communication, because you need to communicate with those who you want to work for. They are more involved in the realization of their own advice and can play an important role in its implementation. This applies to us as pharmacists, because when you are discussing drug regimen and so on, you want to change it, you want to improve it, you want to advise, you are involved with the health team in order to do this. And they're usually cheaper than external consultants. Of course, there are benefits to external consultants, because they have a dispassionate and independent view of an organization. Then clients seems to have more confidence in them. The function of the consultants often demands imposition and firm hand. At times, a consultant is hired to do a dirty job, dirty in quotes. Maybe you want to right size, or you want to change some of your operational modes. It's better somebody comes from outside. One of my teachers used to say that the eye sees not itself. So if the eye sees not itself, somebody coming from outside will be able to see you better than you see yourself. And they have broader experience to call upon as they are involved with many clients. What are the types of consultants you can have? The ones in blue, pharmacists engage in them, professional consultants. You have doctors, you have lawyers, pharmacists, engineers, IT, etc. Strategy consultants, human resources consultants, process consultants. Pharmacists can be process consultants because they can help to design or improve operational processes in specific sectors or industries. Then you have PR, performance, the marketing consultants, because we can operate as marketing consultants too. If somebody wants to improve his organization's marketing ability and so on, you can be involved as a pharmacist. Why is there a need for consultants or for consultancy at all? It is because there is a need for organization to bring about a change due to favorable or unfavorable situation. I remembered when I was at the NEMIT end of year program last year, the MD, Ernest Okafor, did say that during COVID, because of the circumstances of people not coming to buy from his place, he had to make everything, all the processes in his place online. And I'm sure he hired some IT consultants to come and do this for him. This is an unfavorable situation, bringing about a change in an organization. And we experience this every time. Then you want to get an objective opinion on a process or systems, you might need a consultant. Or if you have some specific problems you want to solve, you might require a consultant. Then expert guidance on solving or implementing a solution. If somebody comes in to advise you and propose a solution, you want him to see the thing through so that what he has proposed is workable or not. Consultancy might help to fill a temporary staffing gap, or like I've said before, may be hired to do hard and difficult jobs, staff court and so on. Another important one is to provide training for staff members in clients' organization. In Professor Eru's presentation, he showed us where he was invited to, whether Cross River or Akwa Ibom, to come and teach them or start UDDS in their hospitals. This is part of what a consultant do. You train other people, whether in the your client's organization, so that you can have the knowledge and skills to be able to carry out their assignments. What are the qualifications for consultants? I'm looking at consultancy generally. I'll still look at this in relation to pharmacy. There is no set of qualification, but a minimum of bachelor's degree in relevant fields. Then you will need additional specialist training in your field of expertise. You might train in some core concept of consulting, such as data analysis, project management, get an MBA, and so on. Then you need to network or learn how to network so that you can build relationships, and more importantly, experience, because you need to do the job, carry out the job so that your job will recommend you. I'm happy Professor Eru alluded to it. You might have all the qualifications in the world, but if you are not making impact where you're working, nobody's going to recognize you. It's the impact you can make that allows for recognition. What are the attributes or the properties or the qualities of a consultant? Consultants are resourceful, both human and material. They are current and up to date in their field. If you want to operate as a consultant, you need to be up to date in your field, and so that everything is at your fingertip. Even if you don't have them ready, you should know the source where you can find them so that you are not taken unawares. They are intelligent, knowledgeable, enough to strategically assess situations and proffer solutions. That is, they have to have problem-solving attributes. All these are necessary, even for us. They are observers, good listeners, communicators, and motivators. They are independent and should ordinarily maintain a high confidentiality and are always at the client's service. They have initiatives, ethics, and integrity. All of this, I won't repeat them when we get to pharmacy, but we need to have them too. Because without thinking outside the box or critical thinking, we won't be able to function well as pharmacy consultants. What are the significance of consulting? It allows for specialization in various areas. This is applicable to us. It offers a wide variety of job possibilities. Then opportunities to work with other professionals in diverse areas. In our own case, we are working with other healthcare workers. If we do not work in a team, the impact of our work might not be felt. So we need to be able to work with other professionals, and that has been reiterated to us in the first presentation. Offer the chance to interact widely and broaden one's network. Then it gives you prestige and respect. When you solve problems or when you apply your knowledge and skills, there is this satisfaction that you feel, and that's more than any payment that can be made to you. I think these are a repetition of some of the things we had before. What are the roles and functions of consultants? They add value to organizations by applying their knowledge, skill, and experience to solve problems. And they do this by collecting and analyzing data, providing industry-specific coaching, brainstorming strategies, organizing meetings, giving presentations, and engaging in problem solving. They provide solutions to improve performance. They share their knowledge, information, and advise the organization to make changes and training of client team members. When we get to pharmacy, we'll see all this too, because we want to make things better. And to make things better, you have to change. Things have to change within the organization. And you have to provide information and give all the procedures that can make that happen. Lastly, for the general word, ethics in consultancy. What are ethics? They are a group of rules to which human group adapts itself in order to distinguish what is legitimate and acceptable in achieving certain goals. There are 5 core ethics for consultants. 1, integrity, professional competence, confidentiality, and professional behaviors. We know what integrity is. There is no halfway about it. It's 100%. 1, it is about moral burden, about how much you want to reveal or not to reveal to your client. And we should not cut corners in solving problems or meet temporary challenges in the short term because of the consequences in the long term. Because if you do that, your integrity might be at stake. Objectivity, especially those of us who might be working for industries and so on. Clients want their preferred positions to be endorsed, but a consultant should be objective rather than consider pecuniary gains. If there are things you see when you are consulting which is not good, you should have the courage to point it out that it is not good, to prevent something worse happening in the future. I might, when I'm sharing some of my experience in consultancy in my own particular area, later we'll see how this comes in. Professional competence. We should make sure that everything we go for, we are competent for it. Then confidentiality. We should not divulge information from one client to another. And if we are given any assignment, if there is a conflict of interest, we need to clearly talk about it so that we are not experienced people with insider trading. When they have a knowledge, a stock is crashing, you quickly call on people and they sell and you sell too and so on. So that shouldn't be. Then professional behavior. We should not charge for work we have not done. And we should not use our clients' resources to conduct our own personal activity. I think these are part of ethics. So that is general consultancy. Now we want to focus on pharmacy, consultancy and pharmacy. Pharmacists can serve as consultants to pharmacy practice settings and in medical practice. So we can see here, pharmacists can be internal consultants as well as external consultants. Then pharmacists may require consultancy services from non-pharmacy experts. I talked about somebody improving the way he does his business and he needed an IT expert. So that is part of what we can do. And there are some pharmacists that can serve even as experts for this kind of job too. So now, what is the definition of a pharmacist consultant? I'll read. According to the American Association of Consultant Pharmacists, a consultant pharmacist is a pharmacist who works as a consultant providing expert advice on clinical pharmacy, academic pharmacist practice, public health pharmacy, industrial pharmacy, community pharmacy or practice, pharmaceutical analysis, etc., regarding the use and production of medications or on the provision of hospital and pharmaceutical consulting to medical institutions, universities, research institutions, medical practices, and individual patients. You will see from this definition that our consultancy or consultant activity is not restricted just to the hospital, but it can be in other facets of our practice, because that is one beauty of our profession. It has so many areas of operation. What are the qualifications for pharmacy consultants? You need to have a minimum of BPharm or PharmD in pharmacy. You do your internship to allow you the license to practice as a pharmacist. But to become a specialist, you need additional specialist training in your field of expertise to acquire advanced knowledge and skills for practice. This is what is done at the West African Postgraduate College of Pharmacy, or you can take a master's degree or a PhD. Then you acquire career experience, that is, you get practical knowledge, because without that, you wouldn't have the experience to function well as a pharmacy consultant. Then you build your network, that is a network of relationships, where others who have enjoyed your services will probably be able to tell others about it, so that you get other prospective clients. So I believe that areas of operation of consultant pharmacists is broad. It can be in clinical practice. It can be in medical or research institutes. It can be in community practice, industrial setting, or public health pharmacy. Whatever, these roles of consultant pharmacists differ depending on the work setting. That is, depending on the area you are operating, or notwithstanding this fact, the service provided must be impactful. I think we need to underline that in our minds. If it doesn't have an impact, you are not going to be recognized as such. In clinical practice, it basically entails the provision of patient care using medications to optimize health outcomes of patients. In order to do this, you have to be up to date with current developments in medication management, especially in your area of practice, whether you are in oncology, geriatric medicine, and so on. Work with other health professionals in a team to develop and implement patient care plans. I think this is very, very important. We cannot work on our own, but we work as a team with others. And I'm happy there are some of us who have been working in their settings as a team with other team members, and their work they're very well appreciated, just like the man who spoke before me has said, and we see some of them in operation. You should be able to assess the needs of patients and make necessary recommendations on drug use. You should be able to review medication regimens that are based on the patient background and to assess the suitability, safety, and effectiveness. Basically, and you need to constantly improve your knowledge. And again, I've put that under the general one. You act as preceptors to those who are training, and you even try and educate the other members of the team. In industrial setting, it can be in the development and testing of new medications, solving unit operation problems, including analytical challenges, quality auditing, training of staff members on CGMP, safety measures, etc. For community pharmacy medicine setting, it could be location analysis for new pharmacy premises, financing ideas to improve your pharmacy or setting up new ones, operational aspect of running a pharmacy. I'm not an expert, but I'm just putting some of this up to open our minds so that we see the different areas where we can function. Because one of the tragedies of our profession is that we abandon some aspects of our profession such that other people are finding relevance and coming into them. I think we need to occupy our space so that others don't occupy them. Now, having said all this, I would like to give some case studies. While preparing for this lecture, on my LinkedIn page, there was this lady. I think she's a senior pharmacist at Medicare Cancer Center. And from what she wrote, I just got this slide because I believe that she's offering a service. I don't know whether she's a specialist or not, but she's offering a specialist service in that organization. And I think many more of us should engage in such things. First, she acknowledged being part of the team, the oncology team. And she specified her own contributions to the team and for patient care. One, verifying the appropriateness of anti-cancer drugs and doses for different diagnoses and eligibility for treatment. So that along with others, she's able to look at this. Mixing of drugs in an aseptic manner to avoid contamination. At least no other person can do this. Monitor adverse effects and pharmacovigilance-related activities so that she can make necessary reports on time. Review and recommend strategies for avoiding food and drug interactions and possibly drug-drug interaction prior to and throughout therapy. management of treatment-related adverse effects, and ensuring supportive care. For me, the organization in which this lady works will appreciate our inputs. And I think it's a template so that we need to find a niche for ourselves and make an impact wherever we are. And I think I just have to share this with us. Now, as an academic pharmacist, I've been involved in so many things too. The red ones are the hospital-based ones. The black ones are other jobs. Recovery of aspirin for an international pharmaceutical manufacturing firm. The aspirin powder had too much of salicylic acid in it, and we were consulted to assist. And we're able to devise the method to clean out the salicylic acid and got the thing to be at acceptable level such that a whole batch of so many boxes or so many drops, they were able to use them for their work. They were able to tablet them still instead of losing them altogether. Commercial isolation of pharmaceuticals from natural sources for 2 indigenous companies towards R&D. One was Tomatin. The other was to isolate some of the active constituents of Jubilee. Then I have some experiences in pharmaceutical industries, in pharmaceutical analysis. I won't go too much into details of this. I talked of objectivity the last time. We are external consultants. So going in there, whatever we saw, we report. In some cases, we were doubted, but we persisted in our views. And it so happened that what was happening to the formulation that we complained about was that whenever they measure the active ingredients, before the measurement, the weighing room, and the granulation room, some of their workers would just scoop off the active ingredients and take it away. It was while we persisted and we asked them to look at their system that they discovered this. And the man doing it was caught. If we did not insist, because they were telling us it's not possible, that they've done everything right. So you need to do your own bit and be persistent about it. I'm going to spend some time on therapeutic drug monitoring. My department, during the Carnegie years, about 10 or 20 years ago, applied and we established a therapeutic drug monitoring laboratory in Obafemi Awolowo Teaching Hospital. The first series of things we did, because Professor Mark Ondiola was our vice chancellor and is a psychiatrist, he discovered that some of his patients that he was giving carbamazepine to, he wasn't seeing a change. So he decided to take samples from them so that we were able to monitor for him. And we discovered that there was no carbamazepine in their sample at all, their blood samples. So we brainstormed. So he said the nurses should watch the man. One of them will put the medicine under his tongue and drink water. Whenever the nurses leave, the thing is split out. So they were able to collect so many. The latest one has to do with therapeutic drug monitoring for treatment of chronic myeloid leukemia. Our university was involved, the teaching hospital with some of our colleagues in the College of Health Sciences were involved in the trial of imatinib then. The cost of the drug is massive. But the guy discovered that there is always recurrent drug-related cytopenia. There was poor adherence and response to standard dose. And there was pharmacokinetic-derived resistance. So they were wondering, they were almost stopping the clinical trials. My department got involved and we developed a therapeutic drug monitoring procedure. First, we did a population pharmacokinetics to see, and from that, we were able to see that some people were fast metabolizers, some were people were either early fast metabolizers or delayed metabolizers, and that helps to stratify them. So a TDM protocol was designed to optimize the use of imatinib, and is being used very well in the teaching hospital now. I think with some of these services, we're able to do this. We will be recognized, and there will be no quarrel about accepting pharmacists as consultants. In concluding, I want to just implore us to always do the right thing and to make an impact. It will amaze your friends and confound your enemies. Mark Twain. Consultancy should not promote the ethos of success at all costs, but more assist the clients to develop strategies to promote growth and success of the organization. Thank you.
Thank you, sir.
Wow. Thank you, sir.
Thank you, sir.
Thank you very much, sir.
Quite
Thank you, sir. Thank you very much.
Thank you, sir.
Thank you very much, sir.
Thank you, Prof. We are grateful.
Thank you, Prof. We really appreciate you.
Thank you. Moderator, over to you.
Okay. Thank you so very much, Professor Ogudaini.
Lawrence,
you will agree with me that Prof has done a real justice to this.
So yeah, Lawrence. Ma?
This person should mute.
You need to unmute yourself.
Moderator, unmute yourself.
So sorry, I've been talking since. So I'll take it again. Thank you so very much, Professor Ogudaini, for this elaborate and interesting presentation. He has clearly highlighted the relevance of a consultant. He has also explained who a consultant is and the different types of consultants, both internal and external. He described the different scenarios requiring either internal or external, and also highlighted the need for consultancy, the attributes and qualification. So narrowing it down specifically to pharmacy, he highlighted the roles of consultant pharmacy in pharmacy practice and medical practice, and noted that for whichever area we choose, there is need for our services to be impactful, and stressed, especially those in whichever area we found ourselves, we are most relevant. But what is most importantly needed is that for whatever thing we do, whatever service we render, it must be impactful. I thank you so very much, Prof, for this interesting presentation. So quickly, we'll be calling on from Abdul Hakim Ikolaba. He's a consultant clinical pharmacist and the managing director of Pillbox Pharmacy, Lagos. So, sir, you can take over the mic for your presentation. Thank you.
Thank you. Am I audible? Can you hear me, Ma? Can you hear me?
Yes, you can hear you.
Okay. Please permit me to share my screen. minute, please. Okay. Okay, can you see my screen? Hello?
Not yet. Not yet.
Oh, okay. Okay, maybe I will go like this. Share. Trying to get it on the. Can you see my screen now?
Yes, it's on now.
Okay.
Yes, it's on now.
Okay. Good afternoon, everyone. Thank you for having me. As I've been introduced, Abdulhakeem Abiodun Ikolaba. Before I start to give my experience as a consultant pharmacist in the management of diabetes mellitus, I want to appreciate the ESCO of the West African Postgraduate College of Pharmacists for giving me this opportunity to be at this forum. Thank you so much. Please, looking at the chart, you can see my lecturers, all professors. Because of time, please permit me to stand on the existing protocol. Yeah. Professor Aaron and Professor Ogundaini have said so much about awakening the consultant in you and who a consultant pharmacist is. During the course of their presentation, I was just doing a self-reflection to look at myself to see, oh, am I actually a consultant? And if I am I actually practicing as a consultant? So in a way, the two presentations actually were so insightful that I was trying to do a self-reflection. Now, my own duty today is to talk to my colleagues about my experience as a consultant clinical pharmacist in diabetes management. The presentation will go in this format. I will want to talk about the epidemiology of diabetes itself and its goal, the goal of care, and why pharmacies are important in diabetes care. And I also intend to talk about our role in diabetes care, because it's not enough for us to know our importance, but what is actually our role? What are we doing? And I need to give a reflection of my own diabetes care practice and my own recommendations for the policymakers and my colleagues. Here are some abbreviations and acronyms that will be in this presentation. Now, it's not enough for us to specialize in a disease condition. We need to know about it. We need to find out, is this something, just like what Professor Ogundaini said about the need assessment, is this something that the society are in need of? And when we talk about diabetes, we know that the global prevalence rate is so high. And presently, we know that the prevalence rate in Nigeria is between 5 to 6%, though by 2045, it's been estimated that we have about prevalence rate of 134%. That's across Africa. And when we say across Africa, we know Nigeria, the most populous country in Africa, we have the lion's share, looking at from 6% to 134% just within the next 20 years. So that means there's something that needs to be done. And when we talk about diabetes, we also know that we have uneven distribution of diabetes across the globe. And even in Nigeria as well, we have more people living with diabetes in the urban area than in the rural area. And we have more people living with diabetes in low, medium income countries than in the high, middle income countries. And we also know that this diabetes, a disease, a chronic disease, it has some modifiable and non-modifiable risk factors that really, I mean, these are the risk factors that affect the disease progression. And looking at it, the modifiable one is something of lifestyle that probably, if we do the right thing, we can put the progression of the disease on hold. But the non-modifiable one is something beyond our control. That's whether we are born to a family of a family of diabetes, or whether somebody that have gestational diabetes, and so forth and so on. That's the non-modifiable. And the diagnosis of diabetes also is not static. It's something that is continuous. There are some people today that they have been diagnosed to have gestational diabetes. If the proper care is not taken, they end up having type 2 diabetes. There are some that probably they're having ladder diabetes, and with time, probably they graduate to, type 2 diabetes. So there are so many things that is going on with diabetes. It's keep going because it's one of the chronic ailments that is well researched, that not enough funding is going into the research to see from 1921 when insulin was discovered. There are a lot of research that have been going on to see, how can we cure diabetes? But up till we speak, we don't have a cure for this disease. And we also know that diabetes is a risk factor to other disease. Not so on its own, it's not just killing us, it's also a risk factor to other diseases like cancer. And it causes a lot of premature death and disability. You find out that now when we go to our orthopedic hospital, I think after accidents, I think the next thing that I will give somebody a trauma or amputation, the amputees, majority of them are people living with diabetes, people that are down with complications. And now let's come to the economic aspect. It inflicts an enormous economic burden on individual, the healthcare system, and the nation at all. There was a report that I got that says that the amount of money that was spent on diabetes management in 2019 globally was more than what the likes of the Facebook, the Apple, the Google, the Amazon, their total revenue, the four companies, their total revenue. I mean, what we spent on diabetes management globally was more than what's the sales revenue of all these tech companies. Having said that, we can see that it's a disease that actually needs attention. And if it does, how do we go about it? What are the goals of care? What are the goals? I did say that it's a disease that is being governed or is being driven by some modifiable risk factors. It shows that if the prevention strategies is being placed at the beginning, probably we can reduce the progression of disease, or we can even reduce the prevalence rate if some of these patients end up coming down with diabetes. So prevention of pre-diabetes, prevention of diabetes itself and its related complication. Imagine people living with diabetes, they are moving around, they are unaware that, oh, diabetes has a relationship with my eye, and they keep going to pharmacy or going around putting all sorts in their eyes. So, I mean, it's enough for pharmacists to come in that area. Okay, when you are living with diabetes, you don't just do anything on your own. Fine, we are promoting self-care, but self-care, responsible self-care that needs to be governed by some guidelines, so that once we notice something, we refer to appropriate health facility. Now, screening of individual at risk is also part of the goal of care, because not until when people are living with diabetes, we don't want them to come down with diabetes. So we need to screen, and early detection actually can reverse or reduce the progression of this disease. And collaboration with other healthcare professionals is also key in diabetes management, because it's not something that can be done alone. We have what we call a multidisciplinary team. We have the clinician, we have the physician, that's the endocrinologist, clinical pharmacist, we have the exercise physiologist, we have the dietitian, we have the nurses, we have the ophthalmologist, we have the dentist, we have the dermatologist, all sorts. So we collaborative care. And so these are the goals. And ultimately, in summary, what are we trying to drive at? Haven't trying to prevent, does the prevention, screen of individuals at risk. We want to promote patient safety and also their quality of life. So these are the things that we need to know. Okay, we want to be relevant in diabetes management. Okay, what are the goals? No, I haven't said the goals. Are we actually important in diabetes management? So looking at what I've just mentioned about the prevalence, that globally we have a high prevalence rate of diabetes. It's keep going from 6%, 77%. It used to be about 9% in 2019. Presently, it's about 12.5%. So that's globally. And why Nigeria in 2018, as reported by Professor Uloko and his team, at 2.2. Presently, we have about between 5.8 to 6%. So it shows that it's ongoing. So it needs urgent attention. And we are aware that we have shortage of health care workers and facility. This has been there before, but with the advent of COVID pandemic and migration, I mean, it's now evident that Nigeria, we actually need more healthcare professionals to come in, and who are the people that are actually at the doorstep or accessible to this patient. They are pharmacists. And also we know that majority of people living with diabetes, they are unaware. And there are several studies that says that more than 50% of people living with diabetes, even globally, but more in Nigeria, 1 in 2 people are living with it and they are unaware. It shows that we need people that can actually help us to identify it, because it's part of the goal of therapy. And it's a lifelong chronic condition. The care for diabetes is continuous. It's not something that is static, that we just need, oh, you take the medication just like anti-malaria and that's it. No, it needs to be continuous, because what is good for somebody living with diabetes today might not be good for him tomorrow. For example, a patient that has been prescribed metformin, you and I know that metformin is one of the best medication when it comes to diabetes management. It's even used at a pre-diabetes level. It's even used in pregnancy when, it's used in pre-diabetes. So because it's so useful, does not make it right throughout the therapy. For a patient that has a long duration of diabetes and is now coming down with a CKD, at a particular time when the eGFR is low, metformin will rather be more inflicting more harm than good. So as at that time, metformin has to be removed. So who are those that can help out? I mean, that can help the patient with this is the pharmacist. So because the disease is a lifelong condition, we need an healthcare provider that can always be around. Now, is a lifestyle. Research also have proven, and when we look at the DPP study, that's the one done in America, and the Indian diabetes study also, even the Finnish diabetes study, it shows that lifestyle modification are proven to be effective in terms of managing diabetes, even preventing its complication, and along with medication in other studies. And when we talk about medication, anywhere there's medication, pharmacists are very, very relevant. So it shows that our presence is needed in management of diabetes. Now, it's very rare for you to see somebody that has been living with diabetes for 4 or 5 years without not having like 4, 5, 6 couple of drugs, a couple of medicines. That majority of them are on polypharmacy. And you and I know that polypharmacy, there are a lot of drug-drug interaction, even drug-disease interaction, because some of them are already down with some diseases. Imagine a patient called me yesterday about medication, that's anti-diabetic, and I did not know that the patient is already having some other medication for BPH, and some of this medication will even worsen and the disease state, because the patient is just falling down, not knowing that it's some of the BPH medication that is causing that. But he was thinking that, oh, it's the diabetes medication that was given to him in the hospital. So I had to look at it and say, oh no, it's not your diabetes, it's your medication. So we need to look at, so it shows that we are actually relevant. Now, looking at all this importance, we are not stopping there. The FIP, that's the International Federation of Pharmacists, with the IDF, International Diabetic Federation, and the umbrella body, the World Health Organization, look at all this and say, wow, I think it's better we give pharmacists this opportunity, expanded roles, that, oh, you need to move from a product-oriented service to more of a service driving, so that we need to be engaged with the patient. Already they know us that, okay, we're accessible. Pharmacist is one of the professionals that is easy for patients to come into the community pharmacy or to the hospital pharmacy and, oh, pharmacists that have this challenge, this and that, and they trust us. So the level of trust is so high when clients are with pharmacists than any other healthcare professional, because we are a good listener. Professor Ogundaini said that for you to be a good consultant, you need to be a good listener and also a good communicator. So the WHO has seen that we have those qualities. So it's part of why we are important. And they also noted that Rivera service, pharmacists were like a hub. A lot of patient comes around and we try to refer to different healthcare facility or healthcare professionals that can actually solve the patient problem. Now, medicine experts, this takes me back to the 90s, where we talk about the era of pharmaceutical care, when we pharmacists evolved and the whole world came to know that pharmacists were fine. They knew before, but with the advent of pharmaceutical care from Epra and Strand, so it shows that, oh, pharmacists, we are there, equipped with knowledge, skills, we are doing responsible provision of medication, and we are trying to be responsible for what we are doing. And at the same time, we are doing this to optimize drug therapy, detecting drug-related, medication-related problem, which I just mentioned earlier on from a case of polypharmacy. So this is what, I mean, these are what the WHO has seen in us and said, okay, you know what, these professionals, they are so relevant. So whenever there's going to be any diabetes management, they need to be there. So, and I don't want us to just allow it to go away from us, just like our president said, democracy is so dear. we need to make sure that we hold it dearly. Now, a report from several studies has shown that pharmacist inclusion have been positive. We remember the Advil project that was done in North Carolina in the US that has proven that pharmaceutical care with people living with diabetes, was positive in terms of the clinical outcome. Now, this is just to depict what some of the studies that shows every day and day you see that a lot of researches are going on in the role or the impact of pharmacists in diabetes management. Now, what are we doing? Now, the WHO has called on us, but what are we doing on ground? What are we doing at the moment? Are we doing it? Yes, we are doing it, but only that we need to do it better. So we have been engaged in health promotion. You see that pharmacists, they keep advising patients on how to live a healthy lifestyle to prevent them from coming down with any of chronic ailments. One of it is diabetes. And we try to identify those people at risk. And doing this, we don't just do it by checking their blood glucose. We do what we call we test what we call a risk score. The risk score is just a set of questions, questionnaire that try to identify that, oh, is this patient at risk? Do we need to do a point of care on this patient? And this is what we are doing presently. Majority of the community pharmacy now have point of care where they used to check once they discover that, oh, the patient has already passed, the patient has already failed the risk score, then he or she needs to do a point of care. And from the point of care, if whether the fasting plasma glucose or the random plasma glucose or the A1C has shown that, oh, this patient is positive to diabetes, then it's being referred for proper diagnosis, because just like I said, we work in collaboration with other healthcare professionals so that we give the patient the actual diagnosis, because there are some things that could mask the result. It could be that the patient has just eaten, it could be that the patient is having acute infection, which can even affect the so-called gold standard, that's the A1C, or it could even be that the patient is pregnant, and which also can affect the A1C, or the patient is having CKD. So all this is only when we refer to other healthcare professionals, they will be able to do a proper assessment and be able to give a proper diagnosis. Now, patient education, this is what we've been doing, and we are still doing it on self-care. We encourage them on how to be in charge of their health, just like I said, responsible self-care, to be in charge of themselves, how to take care of their food, how to take care of their eyes, how to take care of their dental. So these are things that pharmacists do, and how to even take their medication. So that's the dosing. So we for some of them that are on insulin, we try to teach them on. And for some that have issue with their diet, we try to educate them. Though majority of the pharmacists, we have limited knowledge when it gets to this. And just like Prof said, we refer to other healthcare professionals like the dietitian or the nutritionist to give them the proper counseling when it comes to that. And medication management, this is our own area. We try to do what we call a rational use of medicine. We try to be sure that, okay, this medicine, is it actually good for this patient? Is it appropriate? Is it the right dose? Is he using it at the right time? So these are the things that we do. And also we monitor for adherence to see whether the patient is taking the medication as when due. And part of what we use to measure adherence is to look at, look at their pill boxes, or we look at their pill boxes. And sometimes some of the patients can be funny, and they just want to impress the clinician by looking at the numbers, and we try to let them know diabetes management is beyond just you having the numbers. Good numbers. We want you to have a good quality of life. So you need to take the medication as when due. We also help them to look out for adverse drug reaction. And we cannot put this aside. That's the CAMS, complementary alternative medicine. Every time you hear people talking on the media, oh, I have a solution, I have this, I have that. So we try to align them for them to know that, oh, this is not it, oh, this one can do, this one cannot do. So in terms of a holistic approach when it comes to medication management, and we do proper referral services. And having done that, some of the pharmacists also do what we call a care plan for these patients. I mean, they have them with them that, from the hospital, they come to the pharmacy so that they have like a replica of case note of what they have in the hospital, they have it in the pharmacy. So, and also collaborative care. This is very key. And some of us, what we do presently, we did not, we are not stopping in the community pharmacy or just in our offices in the hospital pharmacy. Just like Prof said, we have some of us that go on with the cancer team, the oncology team. And in diabetes, what I have been doing, sometimes I visit Gbagada General Hospital, Chevron Hospital, the one at Gbagada, just to be part of the team and see, okay, how can we do it better? How can we give the patient the best? Because when I get feedback from the patient that they are not doing well, I go back because we know that in Nigeria, it's not easy to communicate with the doctor, and maybe you pull a call through, and probably you need to do a face-to-face meeting with them. So there's this communication that, and also what we've been doing also is that we empower our patients. As community pharmacists, as hospital pharmacists, we empower our patients to be able to self-care or self-manage their condition very well. And also to also come up with a particular goal that, oh, is this what you are aiming at? Okay, what is the, I mean, how do you want your diabetes to be managed? Or what do you think is actually the most challenging or the most challenging issue with your diabetes? So it was when they come up with this, we'll sit down together and see how they can. So there's communication. So these are the things that we are doing in the community pharmacy. But now I need to now tell I need to tell the audience, what I've been doing in my own practice. That's the reflection, because I've been talking about general rule. That's what pharmacists have been doing in practice. Now, for me to start, I think it started when I was a student at the University of Lagos with Professor Folatayo, and Professor Bolajoku I know was my supervisor, and our project was on something has to do with diabetes, and I have to test the patient's acceptance or something about pharmacists. What is their perception? And with that, I found that, oh, there are a lot of something that is missing. They know us, but they need so much from us. They need us to do more than what we are doing. So from there, I met Professor Tayo. Oh, this is my findings. And they said, oh, there's a program being done at the West African Postgraduate College of Pharmacy then, certificate in diabetes management and counseling. And Mrs. BC Bright was the secretary of the college at that time. So I enrolled myself, and from there, after the program, I enrolled again in the part 1 to start the fellowship program proper. So that's how the zeal or and Professor said, oh, Akeem, I think you will do well with this diabetes. I need you to, don't just let this project just go like that. Make sure that you give the patient what they need. So now, the first step we did was to actually establish good relationship among the healthcare professional, because part of the training as a student during the clinical at the University of Lagos, we had to do what we call rotation in different units. So during my units at the endocrinology, I was working with Professor Olufemi Fasamade. So with that, the inspiration also was there. Oh, I think we can do, and he carried us along. Oh, this is what you should do as a pharmacist. This is what we're expecting from you. This is So during the ward round and during the lecture. So that alone gave me that bonus. Oh, I mean, I have somebody. So from there, I rode on my relationship with him, with other physicians in that unit. So little by little, we look at, okay, people in Federal Medical Center, Butemeta, Bagada General Hospital, this and that, all of them, when I go there and say, oh, you know, Professor Olufemi Fasama, oh yeah, he's my prophet, he's my doctor. So with this, it opened doors and I was able to mend relationship with most of all these physicians that matters in endocrine. So with that, we established good relationship. We try to do what we call a professional awareness. Try to set up a pharmacy that will be well known that, oh, this is a pharmacy, not a patent medicine store. This is where try to get a good location. So we conducted a SWOT analysis of the premises to see, oh, what can we actually do, and what are our strengths, what are our weaknesses, opportunities, and threats in terms of conducting this diabetes management. And we employ some strategies, and part of it was to planning. Okay, how do we want it to be? How do we want it to be? What program do we want to offer? Because there are a lot of programs that I was being taught that, okay, is it just advising the patient, or is it going beyond that? Is it having a care plan? So, okay, with all this, we try also to look at the payments. Okay, how do we reimburse ourselves? Or this is a community where, or this a system whereby patients, they don't like paying for extra services except for their medication. So how do we make sure that we are well paid? And promotion, how do we make it known to the outside there that we are doing something? And we know that by the law that governs the practice, we cannot advertise. So there are a lot of things that we're looking at. Okay, how do we go? Okay, the level of diabetes service that will be done, which one are we going to do? So, and we look at, and there's something that we learn from pharmaceutical care that once it's not documented, it's not done. Okay, what kind of documentation are we going to be keeping for these services? So these are the things that we sat down and we look at, and we came up with some things. So now with the strength, we found out that our pharmacy was well located in the heart of Lagos mainland. We have National Orthopedic Hospital there. We have Bagada General Hospital. We have University of Lagos Teaching Hospital. We have Federal Medical Center. So we look at, probably we'll be getting a lot of patients living with diabetes coming to our pharmacy. So that is a strength that we are looking at. And we have qualified pharmacists. So that time, it's okay, we have qualified pharmacists, but in terms of the licensure, that's the weakness. We don't have a proper licensure as at that time. It was just the zeal, and because as at that time we've not finished the masters in clinical pharmacy, and I've not even become a fellow. We're still in the college, so we're just okay. How do we do it? So we must ensure that we graduate from University of Lagos and at the college as well, so that we can have, more knowledge and skill to be able to put into place. And patient turnout, I've just mentioned that because of the location, we're just at the heart of 4-5 tertiary institutions that can get a referral from, get patient referral. Now, the weakness, staffing, you can't do it alone. We need to make sure that the other staff, they understand the mission of the project and the vision as well. Because at that time, pharmacists were looking, my colleagues, they were, what are you doing? It's just to dispense medication. How are we going to pay our bill? How are we going to do this? Look at the time we'll be talking to patients. You are using 5-10 minutes so these are some of the issues. And even we that were doing it were not well remunerated, because the time also was taking so much time from us that the other patients, some of them would just leave the pharmacy and go that, you don't have my time, is where I want to see. So it's actually with them, because we don't have enough staff that can actually be on ground. And the finance, we don't have enough money because we need to put some things in place. So those are the weaknesses. So we need to make sure that we improve on our sales revenue to work on the weaknesses. Now, I haven't looked at the weaknesses, but we found out that, oh, we have opportunities that actually was driving us despite the weaknesses and even the threats. Permit me to talk about the threat before the opportunities. We found out that some hospitals were having some similar programs, like we have nurse educator talking to patients before they see the clinician on the diabetic clinic day. So we have patient assistancy. Patient will, oh, what do they want to tell me? There was a patient that told me that, he said it in Yoruba language that, hey, I mean, that's what are you coming here to do? Who are these pharmacists? We know just our nurses, we know just our doctors. So to them, it's something that is new. So they actually did not want to come around. And for the few of them that came, they are not willing to pay extra dime apart from their medication. So they were even asking for a discount for them to be part of the program, not even paying extra money. And the most challenging issue there was our colleagues and other healthcare professionals. They were resistant. They were not buying it that, hey, do you want to take over a job? What are you doing? I'm going to write the Pharmacist Council that you are doing something that is not. I'm going to write a FEMA that what are you doing? There was a time a patient, I was challenged that when does pharmacists start taking history? What is your business? Somebody came in here to buy metformin and you are asking that, who are you living with diabetes? Somebody send you? Are you? I mean, but I didn't allow that to weigh me down, because the same day, the former CMD of University of came in as at that time to the pharmacy and he said, oh, and I reported, he said, oh, no, keep doing your job. They don't know what they are doing. Fine, I know he's a doctor. So, I mean, that's one of the experiences. So it's something that even colleagues will tell me that, oh, what are you doing? You need to make money. This is not it. Pharmacists are, PCN has not look at your license. Your license said you can dispense and do this. You are not supposed to be doing. I said, well, look at the compendium. Look at the PCN compendium. Look at what was written. He said, no, I mean, just some will even tell you that, okay, even with your master's in clinical pharmacy, it's just there. It's not that giving you that authority. I said, then where would the authority come from? So there are a lot of, discouragement from colleagues. And the government policy, I just said that looking at the clinical guidelines, you hardly see pharmacy having any role in diabetes management. You see nurses, you see doctors, and you see community health extension workers. You don't see pharmacists there. Oh, so some will even tell, what are you doing, this and that? So there was a time that I was at PSN meeting and we raised this and they said, oh, they will look into it. They are going to liaise with the policymakers to see how we can be doing this in our various pharmacy. So, but with all these threats, the opportunity we saw is that, the WHO, the FIP, the IDF, they are looking for people or professionals that can help in terms of patient safety, patient quality of life. We look at, okay, with this, we are tend to have to help patients to have their quality of life being improved, and to us, job satisfaction. Our sales increase because we now sell more of anti-diabetic medication, even some over-the-counter medication. Some of these patients comes around and they refill their medication, which is actually good for us. Collaboration. I mean, all the hospitals in my location, that's Yaba area, whether government, private, most of their clinicians will collaborate. Once it's a diabetes case, they ring me, Pillbox, are you there? Please, can you come to my clinic now? Let's look at this together. There's one very close to us, to the pharmacy, that some people even say, Pillbox, do you work in this hospital? I said, no, he just called me for. So this shows that proper collaboration. Okay, this and when they need to refer. There was a patient that had cancer. and was having diabetes also. And the physician was about me. I said, oh no, doc, you need to refer this patient to LASUT immediately. It's beyond your area of competence. And he said, oh, what do you mean? I said, I know you are a GP, I know this, and I know this patient because I know that this patient is having diabetes and is having cancer. And I don't think it's something that you can. And to the glory of God, the patient is alive today. I mean, LASUT was able to manage this patient effectively. So not just dosing the patient with insulin or oral hypoglycemic agent. So collaboration, and with that, there are a lot of patients also that have a CKD that we work together with them at Gbagada, and even diabetic foot ulcer, we work them together with this private hospital around us, even at Gbagada General Hospital, even with Professor Olufemi Fasamade. So this has given us, these are opportunities, and we go into it, and these are the things that we're enjoying. And did not stop at that. The pharma companies were able to recognize us that, oh, you are doing this, you are doing that. Oh, can we partner with you? Can we? And with that, been able to facilitate many diabetes training for many, for some of these indigenous and multinationals in Nigeria. So, which, to the best of my knowledge, my colleagues are really enjoying that, because there was one that was did like just before COVID, and which took them like 6 or 7 months. So it was like 3 modules. So these are opportunities. And before then, I need to mention this. When the program was being planned, it was actually for the nurses, because they were looking at the guidelines. But when they co-opted me that, oh, Abdul, Pillbox, do you think pharmacy will be relevant? I said, yes, I want many people, many colleagues, more colleagues that can do what I'm doing, even do it better. So it's only when you give us this knowledge and skills that we can, and probably it will encourage some of my colleagues to even go back to the uni, or go back to the college, or attend international or local training to see how they can be more skillful in diabetes management. So these are the opportunities we saw that is still keeping us going. Now, I said, I was talking about planning before I move to the SWOT. That, okay, how do we start? So we actually did a need assessment. The need assessment was driven from what my project, that's with Professor Bola Jokua, I know about perceptions of patients, people living with diabetes. A perception to pharmacists, and I found out that they need us. They need this care. They need the counseling. They need medication review. They need. So with that, we pointed that it's something that we need to do. Okay, how do we do it? Is it for 1 month? Is it for 2 months? Is it for 3 months? And we look at what is being obtainable in the Western world. They have what we call structured education, diabetes education program. It's actually not so easy to do. We went into the literature and we found out that there's something that's even being done for sub-Saharan Africa. Okay, let's co-opt and let's see what we can mingle. And from there, we're able to, okay, let's start with this. So we make that, and we look at the program. The program that we'll be doing, we look at, okay, is it going to be face-to-face? Is it going to be one-by-one? Is it going to be in a group? So we look at it. Do we have enough staff? So with that, gradually we started one by one to something that we're doing group. So we're now doing it. We started by doing it weekly, but because there was patient hesitance and no enough staff, we end up doing it monthly. And this monthly, we're not just doing it at Pillbox there. Sometimes we go to Chevron Clinic at Gbagada. We go to the one in the at Chevron Clinic, the one on the Highland. So we do this, and even with the Diabetes Association of Nigeria, they call on us to come and facilitate some of this program. And some religious organizations, they call on us also to come and help them to facilitate some programs for them. Now, we look at the time and space that we have, that, okay, is it enough? When we notice that it was not enough, we collaborate with an NGO in our locality there, and they gave us a space that anytime we need to have a program, or anytime we need to have our diabetes session, we can be using it free of charge. So, I mean, we know that this is not easy, because when we started, we used to pay like 50,000 naira every week to get a space in one of the spaces at Yaba area. So we equip ourselves with the point of care. Some of these pharma companies, Baofeng Pharmaceuticals, donated some machine, Accu-Chek, and all of that. So we invested in A1C machine, because we found out that using just the glucometer is not enough. So we did that, and we're able to do that effectively. We're getting we're getting the strips as at when due, and anytime we notice that there are issues, we refer patients to where they will do a confirmatory test. And all this, we try to have a good documentation system, just like I said, if it's not documented, it's not done. So we have that. We try to have a patient consent form that, okay, for anything that we do, we need to first of all get the patient consent. Okay, are you okay with this? And we get their demography. We try to have their diabetes history. We do all this, and even routine assessment. All this you see in the course of the presentation. The payment system, that was where we got the deadlock. We couldn't do anything, because none of the patients ever paid for the service since we started. None of the patients, because they were not. So when we saw that, because when we introduced and we found out that, oh, patients were just looking, oh, we don't want to pay, and we remove it, and we're doing it selflessly, and we've been recognized, just like Professor Ogoda and Professor Vero, that you'll be recognized. We've been recognized both locally and internationally. So this is enough for us to keep doing it, and at least we're happy that the patients are happy, and with the little, yeah. So, but it's an area which, whenever I see my colleagues, they look at, no, it is not worth doing. That pharmacy, is between business and being a professional. That Pillbox, you are looking at the professional angle more than the business, and you need to balance it for you to succeed in this age, and probably that's where we're having deadlock. So promotion also, we try to advertise, but look at the law. So what we do is that how we did it was to make sure that any patient that walk into the pharmacy, we try to introduce the program to them, and when we go out to the hospital, probably during the health talk or during one of the, so we try to let them know, oh, you can come to our pharmacy for this kind of program. Since we are not allowed by law to start saying, oh, this is a diabetes pharmacy, or so we cannot do that, so that we don't label the patient, and so that is what the strategy that we're able to do. Now, the level of service, I need to say this to our colleagues, that we need to start not doing anything is not an option. As far as if we want to be a consultant pharmacist in diabetes care, there are about 3 levels when we search them into literature. That, okay, what can we do? We find out that, oh, we can do what we call a product-oriented service. We can do like an education service, and then we can do mixture of both. And we find out that, okay, let's start with the products. That's the level 1. The product means that when the patient comes around, we look at their medication, since it's part of our core. That's a medication review, is part of our core. So doing this, we ensure that there's rational use of medicine, and the patients are using the appropriate medication. They are using the right medication at the right time, and they are using the right dosing. And from there, we try to do what we call a self-monitored blood glucose monitoring, to ensure that giving them the appropriate meter, and they try to tell them they should come back with their meter, try to load it. And as at the time we started, there was no app that we can use, but now we have a series of apps that the patient can just bring to the pharmacy and we look at. But as at that time, it was just the machine. You need to bring it. And, but now since the advent of COVID, they don't need to come. They can just share it with us from their phone, or they send it to us via WhatsApp. So that's what we are doing. And not beyond glucose, we also check their blood pressure just to make sure that they are having a good control. Now, insulin injection training is something that is very key, because a majority of patients or people living with diabetes that are on insulin, I could say that 50 to 60% of them, actually, they don't know how to use it. And you can't blame them, because when they get the prescription from the hospital, they don't have that, unless probably they go back to the hospital pharmacy, and the hospital pharmacist really, enlighten them. And I know they do this at LASUT with pharmacist Mrs. Mudupe Oyawole. So they do this there so that they encourage them on how to, because there was a time a patient came into the pharmacy because our location is close to University of Lagos, also Second Gate. And the patient came in with the prescription, and when we brought it out, it's Lantus. And I said, oh, so it's actually insulin, but they didn't tell me it's insulin. I thought it's a tablet or something. So, and I felt ashamed. I was like, wow, so sorry. I mean, it's insulin. They did not tell you, because normally before you prescribe insulin, you need to look at the patient and work on the patient's psyche before you even give insulin. So there and there, the patient had to go back to LASUT, and after like a week, he came back and he got the insulin. But what I'm trying to say is that we need to educate them on how to. So if we are doing this, that anybody that walks into your pharmacy that wants to use insulin needs to be talked to. It's part of diabetes services. The patient will ever come to you. See, we sell insulin to Ogun State. So a patient that lives around the Ogun State, they will come around. Probably, maybe they were in University of Lagos, or they went to church, and they find, oh, I got to that pharmacy, and the pharmacy, they explain out, the next time I need to get this medication, I have to go there. So it's something that is actually profitable. So product initiated service. The third one, the second one is that of the education, and that is a step higher, because it's something that you need to do some assessment. You need to have some skills. It's not something that you just read a book. You need to have some skills. I remember part of the courses that we did at the West African Postgraduate College of Pharmacy. That's a patient assessment, oxalation, palpitation, all these things. So they really helped us, because we're able to look at the patient. Okay, look at the eye, look at the leg, look at the foot, look at the skin, look at the dental arrangement. So from there, we know, okay, this patient, you're already having gingivitis. It's not good for you. You need to see your dentist. Oh, you're having probably you are not seeing properly. You're having blurry vision. Oh, we don't want you to have diabetic macular edema. We refer to. As a matter of fact, majority of the patient that walks into the pharmacy, when it comes to diabetes, we encourage them to do eye screening. We encourage them, even if you don't have high problem, because number one thing that diabetes causes is neuropathy. And once you have neuropathy, the next thing is to have retinopathy. So we don't want it to come down with cataract or glaucoma because early detection can actually put an halt to the progression of the disease. And the foot as well. This is an area that we've done so well, and we've been able to partner with Dr. Mrs. Esiawe. We've been able to partner with Professor Mrs. Anuma. I mean, who is who in diabetes management when it comes to food management as well. And we were part of the first group of facilitator for Diabetes Foods Nigeria, which was done in 2012. Yeah, we're done in Lagos and Lekki. So it was facilitated by Dr. Mr. Esiawe. So we're part of the facilitator then. So, and ever since we've been doing it, and the program was about for 4 or 5 years, and we were consistent for the 5 years because it's got some funding. So we're there, and training upon training, retraining and retraining. So it's made us to be very skillful in terms of identifying when there is risk and referring to the appropriate. And also with the training, also we're able to know that, oh, the wound management, that's even not just the risk, even people that has wound, okay, what kind of medication are they going to apply? I mean, with that, we're able to know that, oh, you don't use hydrogen peroxide on the leg with diabetic foot ulcer, you don't use methylated spirit, you don't use Savlon. If not for the training, we'll not know. So, I mean, these are pharmaceutical products. So we need to know. So with that, we're able to, okay, these are the products that when the wound is getting ill, this is what you should use. When the wound is fresh, when you have calluses, this is what you should use. When it's, okay, this is the time debridement is necessary. So these are things that we're able to know during the training. So with the education, we're able to, and also some of the pharma companies also sponsored us for training in a diabetic map, a conversation map that actually made it easy for people living with diabetes to know, to get it visually and pictorial, because the pictorial, so that it sticks into their brain that, okay, this is what we are saying. And anytime they come for classes like that, and they see it and it sticks in there. And the weight management, we know that the influence of obesity in diabetes. So we're able to explain to our patient that, oh, you need to reduce your weight, 5% to be clinical. I mean, if it's just diabetes, but if there are other cardiovascular, maybe you need to go to 10 or 15%. It depends on the, so we're able to guide them that you don't just lose weight. It has to have, you have to be guided with facts, so which has a scientific backing. So these are things that we do. So we do this in conjunction with all the things that we'll be doing in the level 1. And at level 3, we are doing this as well. In short, we started from level 1, then we found out that we have the capacity where we added level 2. At the end of the day, when I finish as a consultant pharmacy from the college, and I finished my master's, I found, oh, I can even do beyond what we are doing. Encourage colleagues. Then we started the level 3 all inclusive. We do diabetes support group. We do community program. For example, the diabetes and Ramadan, we talk to patients. I remember when I met some of the clinicians, that the doctors, and I was telling them, I would say, oh, this is new. What are you? It's so funny that you are selling medication. You are telling people not to buy medication because I said, no, there are some that is useful. There are some that is not useful during Ramadan, or if they want to fast. So we were able to, and during the World Health Days also, we organize program even beyond our whole locality that we do it. And it's also enable us to we collaborate with Professor, one of the former CMD also Lagos, that we did diabetes and hypertension project together. And it's because they saw that, oh, this is what you are doing, and it's actually rewarding. And we have medication review. This is an area that we do regularly in the pharmacy, because for every patient that walks in now, we don't just look at, we need to do a medication review. From there, we're able to, okay, this is wrong, this is right, and this and this cannot be used together. Or sulfonylurea should be not be used so much in an elderly patient because of risk of fall. Oh, they are 4th generation, 2nd generation. So with the knowledge of pharmacology, we're able to do the medication review effectively and do a proper care plan. And the care plan is not something we do alone. We do it in collaboration with the other healthcare professionals. With this, we'll be able to reduce their risk of complications. People that want to have high problem will reduce their chance of having glaucoma. People that are supposed to have diabetic foot ulcer, we will reduce that. People that had it, we try to improve their quality of life. And we also did some program with University of Lagos also. Sorry, I'm referencing University of Lagos because our pharmacy is just a stone throw to University of Lagos with their human kinetics department. They send some of their students to us to partner with us to do effects of diabetes on exercise. And we did that with our patients, with our clients. We did that for like 3 months. We were taking them with our money to University of Lagos every weekend for exercise, coming back. So, and with that, even when we stopped, they kept continuing. So it's something that is really rewarding. And the nutrition also, we've been able to partner with the dietetic clinic at Bagada General Hospital. We send patients there. Sometimes the dietitian comes around to our classes. I mean, we used to have monthly classes. So to give lectures on how to maintain a good portion and a good composition, not just the portion alone, about their diet. And we do appropriate referral services, just like I said. If it's an high, we know who to refer to. If it's somebody is having issue with the cardiovascular or heart, we know the cardiologist to refer to. We are all just like a team, so we work together. So this is what is being done in even with that, there was a time that we refer a patient to Bagada General Hospital, and the CMD then, Dr. Lawal, I think he's retired now, he called for us that we should come and co-manage the patient in the hospital there, so that the patients would be able to, and we did that for like 2 months, and the patient was well discharged, and everything was fine. But these are things that, with that, it has given us that fame that, oh, this like this. There was a time that when a diabetic foot ulcer patient walks in with this, oh, but you are coming from Yaba, there's a pharmacy there. They will tell you, and when they got by like this, they would have advised you that you shouldn't have used hydrogen peroxide. You shouldn't have used this. So, which, I mean, they know that we know what we are doing. So I'm challenging colleagues that things like this can be done. We don't need to have so much money or fantastic space. Just try to pick from which one can you do, level 1, level 2, or level 3. But everything comes with skills and knowledge, but gradually get there. Now, the documentation that we do over there, we try to have a form for patient consent to be sure that we are not infringing on their rights, that they are the one that consented to, okay, we are having that communication. And because there was a time we were challenged that why are you talking to a patient about his history, about this and that? When does a pharmacy turns to a doctor? I said, no, it's part of our rights. But then to protect ourselves, we need to have a consent being signed by the patient. And so we do all this, get their contacts for follow-up, and to further ensure that there's proper adequate adherence. And we do a checklist for their diabetes screening regularly, that, oh, because you are living with diabetes, you have not done your eye check this year, you have not done your dental check this year, you have not done your immunization. We communicate to them regularly that, okay, this is what you need to do. And which, in a way, imagine a patient was telling me, if a physician was telling me that, why did you tell my patient that he needs to take pneumococcal vaccine? Is he something? I said, oh, it's in the guideline. Look at the ADA, look at the ADA, it's in the guideline. So I don't do it. I'm just telling the patient to meet you so that you can recommend it for them. So it's things like this. Later, we became best of friends with the clinician. So we try to understand their medication and allergic history, document it properly so as to cover that area, because there are a lot of drug-drug interaction and drug-resistant interaction. And routine assessment to do a follow-up to make sure that we evaluate our impact, to evaluate what the advice we've been giving to them. We try to do a routine assessment. We refer appropriately also. So we have that form, and the referral also, anytime we need to do a referral, we document it and, okay, this patient is having so, and the patient has been coming to this pharmacy, we attend this hospital, and is on this medication. This is what we found, and we feel we'll be able to do just so. We refer, and we've been getting feedback from the clinicians that, okay, this is, and it has made us to be well known in the field. And other relevant details also, which I may not be able to capture. So now, what do I have to tell the policymaker during the call? I mean, because in my journey, I found out that we need more training and certification in diabetes care. It took me so long that I have to go for special training, both local and international, make sure that, anything that has to do with diabetes, I try to equip myself. But I mean, we need to do it locally also. At least I'm happy that I heard that we have diabetes care, something that is being done in the University of Abuja, Masters in Diabetes Care now, University of Abuja. So I encourage colleagues also to please look at, it should not just be doctors alone or be nurses alone. So I encourage, and I also want the college also to organize more training on this. And the one I benefited from, the one that actually gave me that faith, it's no more there. That certificate in diabetes counseling and management and counseling. Probably that was the last time it was done, or maybe I want the college to revisit it to see that even if you're a fellow, you can still do this. It will have to your post, not just for that. I mean, it will have to their skills. And I also want the policymaker to sponsor research that will produce national and regional guidelines on pharmaceutical care for people living with diabetes, because it's actually going to help us a lot. That if we say, this is what the American Diabetes said, this is what the European Association for Study of Diabetes said, or this is what the Canadian Pharmacy Association. So let us also sponsor research locally, and probably the new fellows or the incoming fellows, give them this kind of work, and let us see how, and because that will give us this assignment and see how we can come up with a good document that, this is Nigerian guideline when it comes to, and maybe there also should be a collaborative agreement between pharmacists and other healthcare professionals. Let them know that, we are together. So the policymaker should help us. There was a time I heard that the then Minister of Health, Dr. Einare, they had a program about share tax in the Council of Health meeting. So I don't know, things like this should also be part of what we are sharing our tax, but let us have a collaborative agreement that, when the pharmacy is doing this, it can reach out to you. So we don't look down on everyone. So it's the policy, it's beyond what can be done, because these are some of the things that actually weigh me down while I was in the course of the pharmacy practice as a diabetes specialist. Now, also, I also want the college and other policymakers to look at how can pharmacists be remunerated in diabetes care, because it was something that I could not provide solution to. And this is shocking. I noticed that in the national guideline, when we talk about national guideline for diabetes management in Nigeria, pharmacist was not included. The one that was done in 2013, and I have the likes of Professor Fasamade and Professor Andrew Loko and the likes, it's not there. And the recent one that was done, that was signed by just the former Minister of Health, I think it was done in 2017, the national guidelines of diabetes management. Everything they were saying is just doctors, nurses, community health workers, which, the pharmacists, and I noticed that they said they had a program whereby they sat down together for weeks. They call all the healthcare professionals, and the people that came is just doctors, nurses, and lay workers. Please, where are the pharmacists? We need to be well represented. The policymakers, please help us to be feasible, so that when colleagues look at it, they will look, we are part of it, and we have something that is governing us. We can't just, they will not look down on us that it's none of our business. So it's part of our business. WHO has said it, FIP has said it, IDF has said it. Now, for my colleagues, I want everyone to enroll. That's if you want to be skillful in diabetes care, in specialized training in diabetes care. Probably the college will organize one soon. The pharma companies does a lot about this. I facilitated some for, and you do some online. The IDF is doing some online. The ADA is doing some online, and even some universities. I mean, I just mentioned University of Abuja. I hope University of Lagos also will do something like that, because when we have in the north, we should have in the south. And most of the facilitator, I think half of the facilitator are even from University of Lagos. I see no reason why University of Lagos should also have something like that for the south. So, and we should also try to follow a systematic approach to develop your service. Just look at it, you plan very well. It's when we plan, we don't fail. So, but if you fail to plan, then it will be discouraging. But just a step at a time, we see that it's so easy to experiment what we have been taught. And also, we should try to attend professional trainings and seminars. And Prof has said it, that Professor Aaron mentioned it, Professor Ogulaini mentioned it also, that here you meet colleagues and you rub minds together, and you see, okay, this is where you are doing it well, this is where you are not doing it well, and you see those people that are doing it well, they will encourage you so that you'll be able to do it better. They even let you know that, oh, this is the recent training that, professional meetings, and we should collaborate with the NGOs, such as the Diabetes Association of Nigeria. This is very, very key. In every area your pharmacy is, try to look at DAN presence is very important. So, for example, where my pharmacy is, DAN present at Bagada, DAN is at Lasut, DAN is at Chevron. So, and I think they even meet also at Lasut. So these are areas that you need to be part of. DAN, they are very, very key. So you need to, and there are also other NGOs that also do something about diabetes that you can partner with. And pharma companies, all the pharma companies that supplies anti-diabetic medication, I mean, they are ready to sponsor us or to partner with us when it comes to training and retraining. And government agencies also can also be something that we should collaborate with. And with all this, please, it's very important that we are persistent and creative. So, because these are the only way that we can survive, and these are the only way that can make us to do so well. And we need to do what we call audit every year. You see, just like I said, when Prof were talking about who a consultant pharmacy is, and when Prof was also talking about awakening the pharmacist in you, I try to audit myself. Am I actually doing it? Am I actually moving from trying to make the patients actually better? So please, we need to audit it and evaluate the program. Evaluate it every time to ensure that you are actually doing the right thing. Here are my references. Thank you so much for giving me this opportunity.
Thank you so much. Thank you, Pharmacist Coleman. Moderator, are you there?
Yes, I'm here. Thank you, Fami Ekolaba, for this insightful and interesting presentation. He has actually taken us through the experiences of a consultant pharmacist in diabetes management, considering that diabetes mellitus is a chronic condition of public health importance. He has highlighted the prevalence of diabetes mellitus, which is increasing in almost every nation, and Nigeria is not an exception. He has noted that the burden of diabetes is quite huge and requires a collaborative care. He also demonstrated the roles of pharmacists in diabetes care and noted that diabetes is a lifelong illness that requires lifestyle modification, both at the pre-diabetic state and the disease level state. He highlighted the WHO clarion call to strategically position ourselves as consultant pharmacists to engage in healthcare promotion, identify population at risk, medication management that centers majorly on medication adherence, because adherence is an issue when it comes to diabetes management. In his specific experience in diabetes management, he demonstrated that he demonstrated all that he has put in place to strategically position himself as an expert in diabetes management. He used the SWOT analysis as a model to let us know that in any business we do, there must be threats and weaknesses, but actually stressed on the need to capitalize on the strengths and the opportunities and run with it to make sure that we achieve our goal. Good to know at this juncture that his expertise and practice actually has its roots in the Department of Clinical Pharmacy and Biopharmacy under the tutelage of my prominent professors, Professor Bola Joko Aino and Professor Tayo, okay? So during his lecture, he quickly outlined 6 recommendations for all consultant pharmacists to make sure, okay, if you're going to engage in diabetes management and care, because it's a disease that is affecting almost every population. The elderly are not spared, the young population are not spared. So it's a clarion call for all pharmacists to start, no matter the level. And he stressed and described the different levels that we can start off. You have the level 1, level 2, level 3, and stress the most importantly, let us start, no matter how little we think we are, because little drops can make a huge ocean. So the idea here and the effort here is for us as consultant pharmacists to start wherever we are or wherever our clinical expertise resides. So he quickly noted 5 recommendations. 1, to enroll in special, build yourself, build your competence so that you can actually engage in diabetes management. He also stress on the need to follow a systematic approach to develop oneself is very important and crucial, and then to attend professional meetings, which is important because that's where decisions are made. And if we are clearly absent, I don't know who will represent pharmacists when it comes to the issue of recognition in guidelines, and then to hear our voice. It is very important. And then to collaborate with some NGOs that can bring out our services to the limelight. You mentioned maintaining persistence and creativity, which is important. It shouldn't be dampened, even when we've not been recognized. The most important thing is for us to start off and engage in diabetes care and management. And then finally, to carry out annual audits of the services we engage in, to know or to gauge how far we have gone, how well we have done, and all of that. So thank you so very much, Abdul Ikolaba, for this tantalizing or interesting presentation. You're very welcome for that. So before we join into question and answer, I want to especially acknowledge the presence of our immediate past chairman of the West African Postgraduate College of Pharmacists, Dr. Chijioke Onya. He has been in the forefront for the actualization of pharmacist consultancy. Thank you, Dr. Onya, for joining in. So
thank you very much, Dr. Ebele.
So it's now time for question and answer. We can actually, I have seen just only one question in the chat box, but we can also use the raising hand option if we have any question so that we can move ahead. I didn't even realize how the time is fast spent. So let's just start bringing our questions for discussion. So the first question I saw on the chat box is a question from Miriam Mohammed. She asked, how did you get them to pay for the services? She actually dropped in the question when Farm Ikolaba was delivering his presentation on reflection on my diabetes care practice strategies. So I guess she's referring to patients. So Farm Ikolaba, please, can you attend to the question? Thank you very much.
Thank you, Mariam. If you listen to my presentation, I said one of the most challenging aspects of the practice was getting patients to pay for their services. None of the patients paid for the services. None.
Okay.
All right, there's a hand up.
Okay.
Abdul Rafiq.
Okay, please unmute and ask your question. Okay, Abdul Rafiq Mohammed, please ask your question.
Okay, good afternoon. Hello, can you hear me?
So can hear you, go ahead.
Yes, go ahead.
Okay. Sorry, I want to comment the organizers and our professors. Sorry, I want to join others to ask for a record or slides of it. We don't know how we'll be able to get that. We don't know if it can get to us via our emails or various WhatsApp platforms. Some of us, for one reason or the other, today being working, they actually joined lately. So that's my first request.
Okay. To assure you that the slides and the recording will be sent. And
Yes,
that
go ahead, go ahead. That will be taken care of.
Okay.
Secondly, my concern is with PCN now. I don't know how far PCN has gone in terms of licensure. We have our professionals in the group. And I want to know if any of us have idea of the likely challenge that PCN might be having for not being able to license our consultants as such in terms of licensing. I don't know if our senior colleagues have idea on that and how to probably make PCN to begin to think in that direction. That is important that as people graduate from the college, they should have and other professionals, health regulatory professionals too. So that's my point that I want to raise. If anybody can respond to that, Professor of Pharmacy Practice, if he's still with us. Thank you.
Okay, please, before that question is taken, I also want to bring up a question that was put on the chat box. I think for Professor Ogunda or any of the professors can take this. The question said, how can one be able to make an indelible in hospital setting where there are about 10 to 20 doctors and only one pharmacist who is supervising pharmacy technicians? It was on the chat box and I noted it. I think for the professor that talked on consultancy, I don't want to attempt it. I think he can answer that, but there's a possibility. So, Prof, please, can you take these last two questions? Thank you.
Yeah, you mean Professor Gundani?
Professor.
Yes. You want me to take a go first, or you do?
Take a go.
Okay, thank you. Yes. Yes, actually, I saw the one on the how can one be able to make an indelible impact in the hospital setting where there are about 10 to 20 doctors and consultants, but only one pharmacist. Curiously, he said, who is supervising pharmacy technicians and pharmacologists? I want to be sure I understand where the person is coming from. I want to assume that what he seemed to be saying is that there is only one pharmacist in that establishment. And if there are 20 doctors and a consultant, that facility cannot be less than a secondary healthcare facility. And if that is the situation, and it is only one pharmacist, what the first place to start, in my own opinion, would be for him to try and free himself, free some space for himself. What does that mean? There are functions that I regard as robotic. These are functions if a person who is not a pharmacist can actually handle. Counting, leaking, and pouring can be done by machines. What no other person can do for a pharmacist, is actually a direct counseling of the patient. So you may need to free off those other functions to start with. It depends on how much time you will have left if he's focusing on counseling and some other supervisory roles. But if he wants to be able to make an impact in that system, then because he does not have the time, if I were to counsel, I would tell him that you can now use the opportunity of the IT that is obtainable. Use the opportunity of the IT. You can actually begin to do a newsletter that will be capturing things that are relevant, which the physicians doctors would be interested in reading. And this could include how even the medicines are being used in the facility. What you are trying to put across is that, yes, you are a pharmacist. You are not a technician. You are not a pharmacologist. So the people around you should be able to see you distinct from the other technicians and pharmacologists. And that, I believe, will come through the information you are able to give, because you may not have all the time to have a physical interaction. Perhaps if you do this, the next leg is there is a need for the Pharmacists Council of Nigeria to be aware of the situation in such a hospital. Why? Because we also now know that the PCN has responsibility for accreditation of hospital pharmacies. If you can have a hospital pharmacy where you have 20 doctors and consultants, and meanwhile it's only one pharmacist, and you even have pharmacologists operating in pharmacy as well as technicians, and you have only one pharmacist, definitely something is wrong. And I believe that the PCN, if they are made to know, it may just be possible that the state office or somehow would just find a way of arranging some form of visit, even if it is not highly formal, to ensure that the situation is addressed. Those are my initial thoughts as far as that is concerned. Thank you.
Thank you for your contribution. Yeah. I don't know whether Professor Gun wants to say something.
No, I think I associate myself with what my colleague said, and let the person start with that and see how it goes.
Okay.
Yes, ma'am. I also wanted to add something, please, if you don't mind.
Okay. So.
Yeah, the licensing of consultants have come up.
Mm-hmm.
Yes, and also, how much do you charge for your service? Our brother, Abdul Hakim, said that he charged nothing. But the truth is that the patients were paying in kind. They were not paying in cash. Because of the level of impact he was making, the sales he was having based on referrals, which cannot be translated into cash. Those are payments. If we see the payment only in the context of how much naira the service costs to happen to us, then we may not be having it. That's not the complete picture, because the payment that you get from such a skilled service is not only in a consultancy fee of X naira. You have made so much impact that wherever they go, they are talking about the pharmacy. When somebody does not want even anti-diabetic medications, and he wants some other medications, that pharmacy rings a bell. It is payment, for goodness sake. You can't really quantify that in monetary terms. And I think we should not lose sight of that. And we are talking about licensing of consultants. As good as licensing of consultants is, we must recognize that the pharmacist who becomes a specialist by training. However, he becomes a consultant by appointment. In the public service, a pharmacist becomes a specialist by training. The WAPCP training makes you to become a specialist. That does not make you a consultant. Consultancy status is based on vacancies that exist in the establishment that you need to fill, as far as the public sector is concerned. So if now we get licensed as specialists, we can't get licensed as consultants, because consultancy positions are strictly positions that are established in facilities. So we must be able to know the difference between these two so that we don't mix them up. Recognizing all the specialists, there could be a register. I think that was what was recommended sometime. There could be a register of all of those specialists, all of these specialists in our Nigerian context. In the Ghanaian context, it's a bit different. A specialist is somebody who has finished part 1. A consultant is somebody who has finished part 2. But our own Nigerian setting, I think it is a specialist. At the end of our training, the fellow is a specialist. But you cannot become a consultant with the guidelines that are in place unless you have been employed. You are employed to fit into a position of a consultant. The same applies to all the other professional groups. A medical doctor who becomes a consultant in a hospital, he's already a fellow, but when he's appointed, he becomes a consultant. Just information. Thank you.
Okay, thank you, Prof, for this explanation and insights. I'm sure the person that asked the question is okay now. So we have next Modupe Oyewole. Please go on with your question.
Hello.
Yes, we can hear you, please.
Yeah. Good afternoon, everyone. I want to say this is a very good and welcome development. I really enjoyed it, and I'm sure a lot of people, it has been very enlightening for them. So I commend all my lecturers that have really put in so much, and especially Dr. Ikolaba. I know we have done quite a lot of collaborations together in the past. So mine is, should I say, more of a comment. I just wanted to add that apart from IDF, and that there's also Lead Africa, they also do some short courses on, especially on current trends, management, lifestyle modification, and co. Then also, I would also want to add that joining the Nigerian Endocrinologists Association, it's not really a problem if we are willing to join. The only thing is like they told me back then, the person that wants to join will be involved in continuous research. Every year you would have at least one research study that you have done, or something that is continuous. Then also, they also want someone that is consistent. Because I remember with Professor Made, and forgotten, there is another endocrinologist in Ife. Back then, when we had this, there was this diabetes summit that I participated in. I also presented there then. It was during that time that I put up to them that what's going on? Are you not allowing others to join the Endocrinology Association of Nigeria? And they were like, no, why not? But what they found out is that a lot of people just want to join for joining sake, that they are not willing and ready to bring in extras and things that would improve the association, or the having impactful contribution, so to say. So I think it's not a problem. Anybody that wants to join is just, if you have consultants, endocrinology consultants, ones that are approachable in your institution, just approach them and let them know, but be willing to do is not just joining. Why I didn't pursue it further, I joined, but why I didn't pursue it further was when I became very much involved in nephrology. And it seems that I was beginning to have like conflicting interests, though I still do endocrinology very well, they are related somehow. But if you really want to pursue that, to be able to, you need to, like Dr. Ikolaba said, you need to bring in the A game. And I also want to suggest that concerning the remuneration, yes, I quite agree with Professor Aaron that the patient satisfaction and the impact goes a long way. Because I remember that when I started the WhatsApp group, and I noticed the impacts that helped with the patient, especially the ones on insulin, that enough was more than fulfilling. But for the people in the community, I think because I once was asked to come and help out with some endocrinology patients in a community, one big community pharmacy. And I was always going there for 1 week like a consultant, and I was helping to counsel them, help them to do quite a lot of things that helped. On their own, some of them were suggesting that, madam, this kind of thing should be remunerated. They said it themselves. This kind of thing should be remunerated. Though the person that invited me, of course, gave me something, but even some of them felt this person should be remunerated. I think it's just walking along that path and everything, even if it's to add a little bit to the amount of the medication. You'll be surprised that they are the ones that will tell you that, though your drugs might be a little bit higher than the others, but what we gain here is more than we get in some other places. But most importantly, I quite agree with Prof that that's satisfaction. Some people will go ahead and just pray for you so much that you are so overwhelmed when they feel that you have impacted them so much, and they keep, and when you see the way they really believe in you, it goes a long way. So I'll just add my voice to it that we need to be there. If we are not there, we will not be counted. And that's the way it is for all our specialty areas that we're going to, that we would need to put in our best going forward. We need to be known there. Everything will just fall in place. You'll be shocked at the way people, up to now, some of the physicians, especially the ones in internal medicine, they still refer if they think they have a patient that they are having issues with controlling their hyperglycemia, or maybe having some side effects, especially hypo or something, and they feel they have done everything they think. So they still refer, and they ask me to help out with helping to maintain, to review the medication and all those. So it just depends on what you bring to the table, and people as others know that you have something to offer. I think you would always be counted, and that will go a long way. Self my contribution. Thank you so much, everyone, for giving me this opportunity to lend my voice. And I want to encourage us all that is doable, nothing that is not doable. Most importantly, anything we do, we should document. Thank you very much. Thank you, the BPCP, for organizing this. Thank you, everyone. Bye-bye.
Okay, thank you, Famo Yawale, for this insightful contribution, especially for people that are trying to become a specialist in diabetes management and care. She has actually shown us that there are so many organizations that we can join. For somebody like me, that diabetes management is equally, I engage in a lot of research in diabetes. So I've realized that there are so many organizations that we can join to get more knowledge and awareness. Thank you so very much. So I'm looking out for more questions. Do we have more questions so that we can? I thought I saw one hand earlier.
Moderator, I think we need to start thinking of rounding up.
Yeah.
Somebody put on the chat box, I wanted link to Lead Africa.
Oh, okay, yes.
Mm-hmm.
I wanted to request from Famoya, if you can send us the link to join these organizations, that would be nice. Thank you so much. Okay.
So we should do a roundup. We are heading to 2. We should not go beyond 2 p.m.
Okay, I think we are done. No more questions. I want to use this opportunity to thank all the professors. That
Hello, just one question. Hello.
Oh, okay.
Sorry about this.
Okay,
I was just trying to ask. I live in Sierra Leone, and there are colleagues of mine that could be interested in joining some of these organizations, because some of these organizations are not available in country, especially organizations that may be related to clinical pharmacy or things like the diabetes one that is being discussed. And so I want to see, I don't know if there's a possibility of getting individuals or pharmacists in other countries to join some of these organizations. How can that be possible?
Yes, Dr. Lahai, it is very possible.
Yeah, this is Dr. Lahai, Michael.
Yeah, no, Dr. Margaret on the line. Yes, it's possible.
Yeah, thank you.
It's possible.
Okay.
So we can talk on
Here
that.
you go,
You
wine.
can get the information.
Okay,
I'll
for you. But you answer all the time.
All right, moderator.
Okay, thank you so much, our eminent professors, for your time you spent preparing for this webinar. You're well, and our own Fami Kolaba, we thank you very much. Your efforts and time is well appreciated. Thank you so much for this. I don't know, the chairman.
I don't know if secretary is on hand to give a vote of thanks, but one word I want to put across to fellows is do not wait for somebody to pull you out, to bring you out from where you are. Say you are, do something valuable that will add, that will make them recognize you and add value to you. And there's no way you won't be recognized. Thank you. Is a secretary.
Okay, I can see that Dr. Kafo.
Yes, I'm on call.
Okay,
okay
yeah,
so
thank you, Chairman, and thank you, Dr. Onwuchuluba, the moderator. On behalf of the WAPCP Nigeria chapter, I want to thank our speakers for bringing out their time and for the presentations, very, very inspiring and mind-blowing as we expected. And I also want to thank all our pharmacists that joined on this call. It's almost a 3 hours webinar and we all sit back. Thank you also to the chairman of the chapter and for all the people that have taken their time to organize this program. Thank you very much.
Thank you, everyone. Thank you, IPC, Dr. Chijo Konya. Welcome, everybody. Thank you for being here. If you need more information, clarification, please just reach us, Nigeria Chapter ESCO.
Thank you very much.
Whatever information. Thank you. Thank you,
Lisa,
everyone. Thank you, our resource persons.
Yeah.
Yes.
Unfortunately, people have already started going. Is it possible for people to on their camera so that we can take a screenshot of participants? It's coming late though, but I've started taking anyway.
Yes, we still have a minute, so we can do that.
Yes, if you can please on your cameras so that we can have a screenshot. Thank you. Okay, that's fine.
Thank you. Thank you.
Thank you so much.
Thank you, everyone.
You are most appreciated.
Thank you, Chairman. Thank organizers. Thank you, everybody.
Okay, sir. Okay, we are good. Thank you so much. And bye-bye. Do have a great day.